Good afternoon, ladies and gentlemen. I express my deep gratitude to West Bengal Academy of Echocardiography for having invited me for this wonderful conference. And the deliberations have been very fruitful so far. I have been asked to present a case and discuss its detailed diagnosis and management. So, I have been given a patient who is 52 years old, normotensive, non-diabetic, with progressive dyspnea on exertion for 6 months, mild bipedal edema, with an echo showing left ventricle hypertrophy, ejection fraction 64%, grade 2 diastolic dysfunction, and pulmonary artery systolic pressure of 54 millimeter mercury. So from this, you obviously know that this patient has heart failure with preserved ejection fraction, isn't it? The question is, I have been asked to do further echo workup, differential diagnosis, further imaging studies needed, and of course, management guidelines. So with that data, what comes to your mind? What comes to my mind is that this is a type of heart failure with preserved ejection fraction. This could be hypertrophic cardiomyopathy. This could be cardiac amyloidosis. This could be another infiltrative disorder, or it could be obesity-related HFpEF. They all can cause left ventricle hypertrophy, normal ejection fraction, pulmonary hypertension, and diastolic dysfunction. So let us presume for a while that the patient is not morbidly obese, is an average built individual with a body surface area and BMI which fall in the IDF recommended normal range for Indians. So we can delete discussing obesity related heart failure with preserved ejection fraction. Now our patient has dyspnea class 2 progressive. Whenever you see a patient with dyspnea or fatigue, and you think it could be cardiac in origin. Of course, the first thing is to find out whether it is in cardiac in origin, pulmonary in origin, is it hematological cause, it is a psychological cause. Then, of course, if the ECG and X-ray is giving you a suggestion that this could be cardiac in origin, that is because of elevated filling pressures. And elevated filling pressures are as a result of failing heart. And when we talk of failing heart, we have certain risk factors. You need to look at diabetes and hypertension. Both of these are not there in this patient. Coronary artery disease one could consider, but the coronary artery disease doesn't cause left ventricle hypertrophy. Aging, CKD, well, one could discuss CKD. CKD is a very much a possibility in such individuals. AF, of course, let's believe for a while patient has sinus rhythm, myocarditis. Again, myocardial edema can cause actually wall thickness, but usually ejection fraction is not normal. Genetic obesity, we already discussed, COPD, amyloidosis, and valvular heart disease. And the data we have been given doesn't say that the patient has valvular heart disease. So what is our investigative workup? We need to have biochemical profile of this patient, which has been discussed in great detail by Dr. Johann Christopher. I wouldn't go in that. Imaging needs to be done, both echo imaging and non-echo, and some of the techniques of non-echo imaging have been discussed by Christopher. We will apply those techniques to this patient. We also need hemodynamic assessment, saying that patient has a grade 2 diastolic dysfunction and PS systolic pressure 54, probably not sufficient. We would like to know more about hemodynamics, and we will use echocardiography, although in some individuals one can use invasive techniques as well. So let us again revise the clinical data given to us. This is a 52 years male, average built, BMI 27, class 2 dyspnea, 2 episodes of chest heaviness. That is because this is a real case I am going to show you. So there is in addition heaviness. Blood pressure normal, pulse rate is 78, pedal edema, CVS unremarkable. Trop is 137 nanogram per liter and BNP is 260 picogram ml. So you understand that Obviously, somebody who has these kind of things and the natriuretic peptides are increased, this is heart failure. But the patient also has toponemia. The HbA1c is 5.8, normal urine examination, that has a meaning, we can discuss that. And this patient has been treated for acute suppurative axillary lymphadenitis in the past. Now that is important, and although it is written suppurative lymphadenitis, we would come at the end and discuss how important this thing was. So we know that this patient has a clinical syndrome of effort intolerance. There are structural alterations in the heart in the form of left ventricular hypertrophy. There are functional alterations in the form of diastolic dysfunction, pulmonary hypertension. Filling pressures are elevated or not, we don't know. We don't have E2E prime, but we have elevated natriuretic peptides, and we have some objective evidence of systemic congestion in the form of pedal edema. Seems this patient has heart failure with preserved ejection fraction. This is the electrocardiogram of this patient. Now, when you look at this electrocardiogram, poor R-wave progression in V1 to V3, deep TV inversions, V4, V5, V2, V3, V4, V5, V6, L1, AVL, you will think that this is a patient who has myocardial infarction, old myocardial infarction, because ST is not elevated, evolved myocardial infarction. It is also possible this ECG could fit with hypertrophic cardiomyopathy. This also could be a pseudo-infarct due to cardiac sarcoidosis. So those are the things which are going in my mind when I am reading about this. Does it fit with cardiac amyloidosis? Well, you could say that could fit with cardiac amyloidosis although the voltages etc. are reasonable, but a pseudo-infarct pattern can occur in a patient of cardiac amyloidosis. Okay. The lipid profile of this patient has been done. This is essentially normal and we can skip it. Now, as I said, this patient has heart failure with preserved ejection fraction, and we will again review how to diagnose heart failure with preserved ejection fraction. There are two diagnostic algorithms. One, of course, Mayo algorithm, also called HFpEF algorithm, and other is European Society of Cardiology 2019 algorithm. This is the ESC algorithm. You have to have functional and morphological and biological evaluation, each given 2 points. And our patient has functional abnormality, morphological abnormality, and biochemical abnormality, 2 + 2 + 2, 6 points. Points more than 5 indicate definite heart failure with preserved ejection fraction. But interesting thing is, if you use the American way, the Mayo formula, then our patient is not heavy, patient is not hypertensive, patient has no atrial fibrillation, patient has only one pulmonary hypertension, so 1 point for pulmonary hypertension, patient is not elderly, 52 only, and filling pressure is elevated, so 1 and 1, 2. What is the possibility with 2.2 score? 40% possibility of HFpEF. This is just to tell you that these algorithms for HFpEF have their own limitations. Here, the European algorithm seems to be giving us diagnosis of heart failure with preserved ejection fraction. The Mayo algorithm, which the Americans follow, is telling that, well, you need to do something more to find out whether this patient has heart failure with preserved ejection fraction. So we have a score of 6, which means it is a definite heart failure preserved ejection fraction by ESC criteria. However, by American criteria, you probably would need more tests like diastolic stress test or non-invasive or invasive hemodynamics. We will skip for a while that whole thing. But come back to the patient. Patient has ejection fraction 64%, left ventricular hypertrophy, grade 2 diastolic dysfunction, pulmonary artery hypertension. So this is a high gain system in this patient, and you can think this could be usual HFpEF, but at 52 years of age HFpEF, that is little tough in a non-diabetic and non-hypertensive individual. Hypertrophic cardiomyopathy, sure it can be. Coronary artery disease, unlikely. How do you explain actually in a patient with coronary artery disease, left ventricular hypertrophy, although it can occur? Some patients. Amyloidosis, sure. Aortic stenosis, we can auscultate and rule out aortic stenosis, and if in case we are dumb enough, the echo is always there to tell that this is not aortic stenosis. Okay. Point number 1. Whenever there is heart failure with preserved ejection fraction, 50% patient have no left ventricle hypertrophy. Another 50% have left ventricle wall thickness being increased, and those are the individuals who can either have hypertensive HFpEF, metabolic HFpEF, infiltratory HFpEF, or these patients could have cardiac amyloidosis, more likely ATTR, but of course in our experience AL amyloidosis probably is more common. Okay. Prevalence of ATTR in HFpEF is anything between 5 to 17%. Community prevalence from the Mayo data is about 6%. So you can't really ignore, at the back of your mind, keep in mind that this patient could have cardiac amyloidosis. Okay. But in cardiac amyloidosis, you should have clinical echo and biomarker red flags, and we so far haven't seen any clinical red flags. Echo, ECG red flags possible. Biomarker red flags possible because the troponin level is raised. A typical hypertensive HFpEF does not have actually the troponin levels which are increased. So something to suggest it could be amyloidosis. But let us come back to our patient. We look at the inferior vena cava, which is not dilated, but it is collapsing little less than 50%. And the transmitral flow pattern in a 52-year-old gentleman is pseudo-normal, so we need to actually evaluate it further. But let us look at echocardiogram. Here is the echocardiogram of this 52-year gentleman, normal tendency, non-diabetic. Septum is thick. There is asymmetric septal hypertrophy. But if you see the short axis view, the hypertrophy is unusual for anterior septum, anterior wall, and lateral wall. What is more, the ejection fraction probably is normal. It's pretty much contracting well. 64% is all right. Patient has mild pericardial effusion, left atrium is enlarged. That all can fit with heart failure, preserved ejection fraction, with hypertrophic cardiomyopathy. Also can fit with cardiac amyloidosis. 25% of the patients with cardiac amyloidosis have asymmetric septal hypertrophy, where the septum is disproportionately thickened. And 4% of these individuals have picture resembling hypertrophic obstructive cardiomyopathy. So you still can't get out of amyloidosis, right? So we also see that there is evidence of right ventricular hypertrophy. If you look at the RV free wall in 4-chamber view, and also of course some part in short axis views, we'll see that there is right ventricular hypertrophy and there is some pericardial effusion. Okay. E2E prime medial 15, lateral 16, indicating filling pressures elevated. So it fulfills that criteria of raised filling pressures and hence heart failure. Remember one thing, that this E2E prime more than 15 has a very high specificity for telling that filling pressure elevated, but its sensitivity is very low. Sensitivity is more like 24 to 30%. So if you have an E2E prime of 5, that does not mean filling pressure is not elevated. Keep that thing in mind. Here filling pressure is elevated, but the reverse, this patient could have an E2E prime of 8. That doesn't mean the filling pressure is not elevated, because sensitivity of E2E prime to predict filling pressure is very, very low. And this is actually a meta-analysis of all the studies published in 2016, and the data comes from Birmingham. Okay, so what about, we have been given to understand that this patient has PS systolic pressure of 54 millimeter mercury. We didn't get much TR, very good TR images, TR spectrum, but looks like it is about that. You know, it's coming close to 4 meters per second when you have changed the color. So let us believe that PS systolic pressure 54 millimeter mercury in this particular individual. What more you can do in echo? We have been asked what more echo data you can get. You push contrast, you can see the wall thickness better and the distribution of wall thickness better. Here is the parasternal long axis view. The ejection fraction looks pretty good. What is unusual? What is unusual in this particular case? Perfusion is pretty good in septum. It is very good in infralateral wall and apex. It's good in all the other segments in short axis view. Now, note something. Pericardial effusion is present. Both the layers of pericardium are thickened. Okay? Keep that thing in mind. We'll come back to this later on.